Well, I think we'll start. Well, welcome everybody. Happy New Year. It's nice to see so many people at the beginning of 2006 for the resumption of our Waterloo Institute for Health Informatics Research Seminars. It's our pleasure today to have Mary Thompson here to speak to us. She's going to be talking about the quality of survey data. But before we get to that, I have a couple of announcements that you might be interested in. Our next Smarter Health seminar, and I have flyers over here if you're interested in picking one up at the end of the seminar here, will be given by Dr. Ian McKillop on January 25th. That's a Wednesday at 3 o'clock. And he's going to be talking about drowning in data. What's a healthcare provider to do? So it should be a very interesting talk. Ian McKillop is the J.W. Graham Research Chair in Health Information Systems and Associate Professor in Computer Science and Health Studies in Gerontology. So it should be an excellent talk. By the way, this is not an enticement to come to the seminar, but if you register and attend the seminar, you would be eligible to win a BlackBerry. The next research seminar in this series will be given by Justin Wan, who is also in computer science. I don't have the title of his talk, but that talk will be on February the 8th in this room at 12 o'clock next month. So I look forward to seeing you all back for that talk. Without any more further announcements, I'd like to introduce our speaker. Mary Thompson is a professor in the Department of Statistics and Actuarial Science. She's the co-director of the Survey Research Center at the University of Waterloo. She's an investigator in a series of international surveys on tobacco control. The chief or principal investigator for that is Jeff Fong in psychology. And she's also the director of the Associated Data Management Corps. I don't know how she has time for all of this. She is currently focusing her research on the construction and use of survey weights for longitudinal, multi-level, and latent variable models, and resampling methods for internal estimation and testing. Interval estimation and testing. Mary's also a member of the Institute, which I'm very pleased to note. And on a personal note, I'd like to say that in my graduate studies, Mary was one of my most fond, memories as being one of my teachers. She taught me statistics in my graduate studies. It seems like just yesterday, Mary. And where did all that time go? I just don't know. Anyway, it's my pleasure to welcome Mary to this to speak to us today.
Well, thank you very much, Shirley, and thank you for the invitation to speak. I was given a free range of topics on which to speak, and I thought, what do I know that has anything to do with health informatics? And so I decided that to some extent, the kinds of quality issues that we see in survey data are relevant and might be of interest. I thought, oh well, the audience will be full of people I don't know, and I see that quite the contrary is true. So I like to warn you that this is not a terribly serious overview of this vast and important field, the quality of survey data. I have not been particularly punctilious about references and so on. If there's anything you'd like to follow up further, I can probably point you to the right sources. So I'll start off just by talking about the importance of observation. We hear the term evidence-based practice a lot, and that, of course, requires data, it requires evidence. We often think of such evidence as being experimentally derived, but in fact, observation without experimentation can also be very important. There's an interesting article in the most recent issue of Statistical Science, which is actually dedicated to the commemoration of the 50th anniversary of the book, How to Lie with Statistics. But one of the articles is by Sally Morton about ephedra, which is a dietary supplement for weight loss and the improvement of athletic performance. And it was on the market and being used by people, but the FDA banned the use of ephedra in dietary supplements toward the beginning of 2004. And it was on the basis of a study done by Morton and colleagues where they looked at all the clinical trial data. And it's important to realize, I guess, that since ephedra was being looked at as a dietary supplement, the testing did not have to be as stringent as for a drug. But they looked at the clinical trials data and found no adverse events, no apparent harm to the trial participants. However, there were cases cropping up all over the place of cardiovascular events and deaths, in fact, that appeared to be connected with, or possibly connected with, the use of ephedra. So they had to supplement the clinical data with observational data, which in this case consisted of case reports, reports from on these adverse events where ephedra may or may not have been found to be present. And the FDA then had to weigh the experimental and the observational data to try to come to a conclusion, and eventually did ban the use of ephedra in dietary supplements. So this is sort of almost administrative observational data collected because there was a database of reports from these adverse events. Survey data are akin to this because they're based usually on observations of populations without experimentations on any large scale. But it's possible with surveys to observe risk factors and, of course, the occurrence of outcomes, disease and adverse events and other things. So they provide observation on a wider scale than clinical studies, and also more than these particularly focused studies, they tell us to what extent the phenomena we observe are replicable. And I like the phrase from a very well-known paper of Cochrane in the 70s about the uses of observational survey data, where he says that there's really something important in knowing whether these phenomena are, in the words of the old song, the same the whole world over. This was his justification for urging more study of large-scale surveys and associated observational studies. So what constitutes a survey? I'm thinking of a survey as being a scientific survey where you have a study population which is, in some sense, close to your target population. You have a sample chosen from that population through a probability design, if that's feasible. You have efforts made very strongly and carefully to measure the characteristics of sample members, and then a generalization from the sample to the population of interest. When we come to talk about quality, as I said, that's a vast subject, and I thought it would be interesting just to look at some examples of surveys and what we think of when we think of survey quality. The first one is a survey on the prevalence of herpes simplex virus 2. And this is reported on the internet. It was commissioned by a pharmaceutical company who were interested in some kind of estimate of whether of what the prevalence of herpes was in the United States and whether it was on the increase. And because of limitations on their financial resources and the logistics and ethical considerations, they were not able to go to individuals and test them for the presence of the virus, but or antibodies to the virus. But they had to rely on the cooperation of physicians. So they took a survey of people through primary care physician offices. Because their funds were limited, they took 6 randomly selected offices in each of 6 cities. And I think you can tell from the names of the cities that those were not randomly selected. But they did do a probability sample of physician offices from the relatively affluent areas of each of those cities. From each PCP office, they recruited approximately 150 volunteers, and they had a total sample size of 5732. They were able to use 5433 in their final sample, and they were able to essentially take a blood sample and test for the presence of HSV2. So there are a number of things about this survey where they had, obviously, compromises had to be made that might affect quality, including the volunteer sample and the fact that they're looking at relatively affluent areas. Their finding was that the overall weighted seroprevalence was estimated at 25.5%, and they have a confidence interval 20.2% to 30.8%. And that looks like a pretty wide confidence interval for that high number of subjects, but you have to realize that they would have had probably to introduce survey weights to compensate for the fact that their volunteer sample might not be representative of the cities in terms of age and sex and so on. So that the observations would be weighted. Moreover, the sample is clustered into the caseloads of these physician offices. It is very likely that a caseload of a physician might be more homogeneous than the population overall, and so that while it looks as though you have 5,500 subjects, the effective number of subjects is much lower. So those kinds of things would be taken into account in this confidence interval, which essentially quantifies the sampling error in the survey. I guess there's not too much problem with measurement error because you're just measuring the presence or absence of the HSV2, but there could be a fair amount of bias connected with the fact that it's a volunteer sample. They wouldn't be able to quantify that without further field work and assumptions. So that this is something that it's a pretty honest confidence interval, but it may not express the full uncertainty. So their real problem here is that they don't have much of a way of getting at the population. They don't really have an adequate frame. Here, in contrast, the U.S. Health Statistics Agency has a lot more resources, and about every 10 years they're able to conduct a survey called NHANES, National Health and Nutrition Examination Survey. And here they do have a population frame. They're able to divide the country into about 4 regions, and then at the first stage they would select a probability sample of counties, about 80 counties. And then, to oversimplify greatly, what they would do is take the selected counties, subdivide those into smaller areas, map those areas, subdivide them, at some stage enumerate households in selected areas, and then go to the households and select the sample of people. They have mobile clinics, which allows them to do physical examinations and in-depth interviews, and allows the possibility of taking blood tests. Their response rate is pretty high overall. I didn't include it here, but it should be pretty high. The blood test response rate was, in one publication that I saw, given as 75%. So their estimate around 1990-91 of the U.S. population over 12 positive for HSV2 is 21.3%. Not far, really, from the estimate obtained a few years later by the 6 cities survey. Their confidence interval is a lot narrower, and their prevalence estimate a lot more trustworthy, because their sample size is larger, and because they don't have to rely on volunteers, essentially. Yes?
Is there any adjustment necessary for missing blood, or the people who didn't get blood tests?
Yeah, so Joel is asking is there any adjustment necessary for the people that didn't get the blood test. I don't know whether they used that in this 95% confidence interval or not, but it's certainly worth asking. Yeah. Yes, I did a lot of my research on the internet, as our students do, and I have this from actually a PowerPoint presentation, which also showed some results from NHANES 4, suggesting that the prevalence went down from 91 to 2000. Okay. Now, the herpes population of interest was the broad general population. The problem is a lot more serious when you're looking for a population that's relatively rare, and one for which it's very hard to find any kind of a sampling frame. And one example, of course, would be intravenous drug users. For various reasons, agencies will want to take surveys of intravenous drug users. And a brief survey again of sort of internet examples shows that in most cases what is done is to take as a sort of a surrogate for a frame a collection of locations. So it's rather like the Six City study in this respect. You take locations like needle exchanges, community drug team places, drop-in centers, outpatient clinics where intravenous drug users might come and attempt to volunteer respondents from those places. When you're doing that kind of thing, of course, it's very, very difficult to quantify the error in estimates of things, and part of the difficulty is that you don't even really know what part of the population you're being able to survey. There's been recently a survey on safer injection facilities and the likely clientele to try to estimate the likely clientele for these facilities in Vancouver. And in that case, it was felt that taking the composite frame of places where the IDUs were likely to come was not adequate for their purposes, because they're actually interested in reaching the people that might not come to such places. So they recruited by what they called street recruitment, which might include recruitment from these places, but also what's called snowballing, where you try to find out from the people you recruit at the first step who else might possibly be in the population you're looking for. And this is something that's still a matter of a lot of research. The techniques for doing this, such that down the road you might be able to get reasonable and trustworthy estimates of the size of the population of IDUs or other attributes of the population. Another issue where agencies are often interested in trying to measure prevalence has to do with alcohol dependence or problem drinking. And here again, it's a rather difficult thing, but this time it's because of measurement issues. It's quite possible on the usual kind of survey to ask people how much they drink, but that doesn't really ask them, whether they are dependent on alcohol, whether they have a drinking problem. It's of interest for all kinds of reasons to try to estimate the prevalence of problem drinking. And so it's interesting to look at the various methods that have been devised to try to measure this. The NHANES survey, which has these mobile examination centers where interviews face-to-face can be conducted, has one kind of instrument which actually includes questions like, have you had a drink in the last half hour? Whereas the Canadian Community Health Survey, which in cycle 1.2 simply had a straightforward questionnaire to be administered either I guess, in person or over the telephone, has a battery of about 34 questions, just trying to measure alcohol dependence alone. And the questions have to do with the extent to which your drinking may have caused you various kinds of problems in the past. So if you were to look at alcohol dependence prevalence figures from these two sources, they would mean quite different things, probably. And that would have to be taken into account in assessment, at least, of the quality of your comparisons. Now, we've been working a lot recently on surveys of smoking behavior, and this doesn't have the same kind of problem, I guess, because smoking is not such a sensitive issue as alcohol use, and it's much easier to measure strength of addiction to smoking through cigarette consumption and the use of questions like the Fagerstrom question, how soon after you first wake up do you smoke your first cigarette? So here it's possible to get prevalence figures by surveys done even over the telephone. And the set of questions is pretty well agreed from jurisdiction to jurisdiction. So the results tend to be comparable. But it's tempting to do these kinds of surveys over the telephone because it's less costly and because also your sample is not clustered the way an area sample would be clustered. The N. Haynes survey that I talked before, the first stage is counties, and this huge sample is taken from 80 counties, whereas for an RDD survey, although you would use counties at the first stage of selection, you wouldn't have to limit yourself to 80 for a survey of smoking prevalence. The International Tobacco Control Survey that we've worked on in the 4 countries, Canada, US, UK, and Australia, is random digit dial. The respondents are essentially approached via what are called cold calls. And in Canada, in wave 1 of the survey, which took place in 2002, the response rate at the stage of recruitment of respondents using compensation of $15, I think, as well, was 50% or thereabouts. So this is pretty good, actually, for a telephone survey, but it's low if you're trying to think in terms of a really precise measurement of prevalence of daily cigarette smoking. In fact, we don't really use the survey for that. We use it for other purposes. We use it for asking smokers about their attitudes and beliefs and the kinds of anti-smoking policies that they're noticing and that kind of thing. But we don't use it for prevalence because of this response rate. Also, we have here in Canada a couple of Statistics Canada surveys that can be used as benchmarks for our survey, and to which we essentially calibrate our sample. CTUMS, the Canadian Tobacco Use Monitoring Survey, is a telephone survey that has a remarkably large response rate of back in 2001 to about 77.5%. The Canadian Community Health Survey that many of you are familiar with is a mixed mode survey, and back in 2001, 2002 had an 85% response rate. Interestingly, the prevalence results from CTUMS and CCHS are different. And it's not completely clear why this would be, but it might not be too surprising that the prevalence rates are higher on the whole from the CCHS. And that part of the reason for this is likely the fact that much of the sample was interviewed face-to-face, where it's a little bit more difficult to deny smoking if you're a smoker. But of course, then for our ITC survey, we had to decide which of these two to use in calibrating our weights, and we chose the CCHS because it was a larger sample. It was taken from an area frame, essentially, and the RDD component was small, and to a large extent, the data collection mode was face-to-face, I think about 50%, as we'll see on the next. So physical activity, this is one that has come up in particular with a study that Susie is working on there. There's Stat Canada has issued a warning that because of a change of mode between the 1.1 and 2.1 cycles of CCHS, there is a change in the measurement of certain variables that seems to affect prevalences, proportions. And one of them is physical activity, which is, of course, of great interest, particularly since it's felt that actually there are trends in physical activity. Physical activity has gone down in the last few years because of various factors. A number of us, of course, blame email for this, but things like that. So the CCHS in the 1.1 cycle, 80% area frame, 20% RDD, and 50% by telephone, CATI, and 50% by personal interview. CCHS2, 2.1, 50% area frame, 50% RDD, and 70% of the interviews by telephone interviewing. So when we're thinking of survey quality, there sometimes compromises that have to be made in order to be able to collect the data do have an impact on not just on quality in the abstract, but on inferences that we are interested in making. So when we come to talking about survey error systematically, we usually talk about the various sources of survey error. Coverage error means essentially inadequacy of the sampling frame And I think the 6 cities is an example where that might play a large role. Non-response error is essentially the bias due to people who respond having different characteristics from the people who do not respond. This can be, we think, in some cases at least, quite serious in RDD surveys, although maybe less serious when you're using analyses that compare results from RDD surveys that all have about the same response rates. And then there's measurement error, which might come about just because of inadequacies in the measurement instrument, or something to do with the interviewer-respondent transaction, as in the case of physical activity. The other 2 components, I've talked a little bit about sampling error. This is the kind of thing that is being measured in most public reports of surveys when they talk about sampling error. Opinion polls say within 3 percentage points, 19 times in 20. They're thinking of a sampling error. And that's simply the error due to the fact that you're taking a sample from the population that you're trying to generalize to. And we note that the clustering of the sample, as in the 6 cities survey, tends to increase sampling error. And that means that 2 surveys that with the same sample sizes may not necessarily have the same precision in terms of sampling error. The other component that should be mentioned, and this comes in at every stage, has to do with what we might call gremlins or human error in the operations of the survey. When you're carrying out a large-scale survey, you're actually dependent on the careful work, the meticulous efforts of many, many people. And to some extent, you can control this and reduce it through electronic data collection methods and so on. But these kinds of problems are there. If interviewers are allowed to choose the units to sample, they may deviate from their instructions. They may make errors in the data collection and data recording. Then when the data come back to the central office, there can be errors made in data cleaning, data storing, data retrieval, failure to get the right files at the right time, that kind of thing. So at any stage in trying to get together a good, clean survey data set, there need to be many checks and balances and lots of patience. You'd think, oh well, I've done my data collection by computer-aided telephone interviewing this week. I have a data set. No. A couple of weeks, 3 weeks later, you may have a data set. An important part of survey quality just has to do with the efforts of the people involved at all levels to try to get things together. I don't know if many of you are interested in family history. maybe most of you are too young to be interested in this, but I'm interested in family history, and it's hard to see this, but it's a PDF of a sheet from the 1911 census, which has just been released to family history buffs. So you can get these things, and you can see that there are lots of cases where the census taker crossed things out and sort of modified things, and one hopes always in the right direction, but it's rather hard to read them. There'll be lots of people out there who are volunteer transcribers of these things, who are going to make the 1911 census available to people who are doing genealogical searches online. And what comes out of there is going to look very clean and crisp and accurate, but always there's something like this behind it. And it's sort of useful if you're dealing with survey data, if you ever have the chance actually to go behind the scenes to look at the original forms and the original sampling sheets and so on. And they'll look like this. So just a... So coming to assessment of survey quality, since there are always imperfections and since there are always compromises, it's useful to think, do the conclusions stand up under scrutiny? Are the conclusions all right? Or could a hostile critic explain them away? And in the case of the 6 cities survey, for example, the conclusions might be, oh well, even in a relatively affluent part of these 6 cities, the prevalence of HSV2 is higher than you might think, and a matter for concern. And that conclusion is probably quite valid, despite the difficulties of the acquisition of the data and the sampling compromises. But on the other hand, if a great deal of care isn't paid to survey quality where it's possible to pay attention to it, the results are very vulnerable to criticism. The classical approach to achieving survey quality that many of us sort of grew up with is simply to examine these components that I've talked about and where they might come from, and try to minimize each one. So for example, with non-response error, one very important thing to do is to make sure that your questionnaire or interview schedule is as well constructed as possible and flows as smoothly as possible. A great deal of non-response comes from people starting surveys and finding that the first 2 questions are not applicable to them, or the response options from question 3 are meaningless, and the people then will give up. So having a very good survey instrument which is respondent friendly is very important in making sure that non-response is not higher than it needs to be. So things like this has been known for many, many years, and it's part of the established set of methodology for achieving survey quality. There was a book a few years ago, maybe about 3 years ago, by Beamer and Leiberg, Introduction to Survey Quality, which takes a total quality management approach and tries to look at the whole survey operation, have the survey organization set goals in terms of all aspects, and people management in particular. The typical goals would focus very much on staff training, streamlining of questionnaires, introducing checks, and so on. The International Tobacco Control ITC China survey will be going into the field soon. Changbao has been working on the data, the detailed instructions to the people who will be carrying this out in China. This is going to be a very large operation, rather difficult to manage because it's in 7 cities, which are far apart geographically and coordinated in Beijing, and so there have to be detailed instructions at every stage and as much as possible motivation of all the people involved to collect data very carefully. There has to be training where people actually try things out and role play and so on. Is there still going to be audio recording of interviews yet? So that there will be that backup in case of difficulty in trying to figure out what has happened with the data collection. An interesting new book that I just recently looked at is by Herbert Weisberg. He's published by the University of Chicago Press, and he is closely associated with the Survey Research Center at Ohio State in Columbus. The subtitle is A Guide to the New Science of Survey Research. And he talks about, I guess, the same kinds of things, the sources of error, but also he talks about trying to make more systematic the trade-offs among survey errors, survey constraints, including cost, time, and ethical considerations, and what he calls survey-related effects, like mode effects and what we call time in sample effects, the effects of being in a longitudinal survey for a number of periods. One of the chapters is called, I think, the response rate challenge. And part of the reason why people are talking in terms of new science of survey research is that response rates are going down unless new and heroic methods are made to try to get people to respond. And there's a great deal of work being put into trying to refine the methods for getting people to respond, and also for trying to account for those in analysis. There's an interesting PowerPoint on the web where David Northrup of York talks about the rapid risk factor surveillance system, which is carried out from York. And he asks towards the beginning, what did it take to get the 62% response rate for the RRF SS. And this is a telephone survey, but with an advanced letter and a number of other features that are, I guess, we could call state of the art for trying to persuade people to respond over the telephone. So the role of statistics, on the one hand, to quantify the survey error, and on the other hand, to the extent possible, correct inferences, taking into account missing data and measurement error and that kind of thing. There's some interesting work being done by Paul Beamer and colleagues on ways of improving measurements of sensitive things like drug use, using latent class analysis, where there's a model which says, okay, the true drug use is hidden, it's unknown, it's latent. And then there are various ways of measuring that by direct questioning or by indirect questioning. How do you put those measurements together and come up with an estimate of the latent quantity? So this is something that is interesting because it leads to new ways of designing such studies, as well as ways of looking after the corrections at the end. There's a new journal, just one issue. It's a takeoff on the Journal of Official Statistics, and this issue was in honor of Lars Leiberg, who was the founder of the JOS. So you can find this also on the internet. Has articles like these: perfect quality in the Swiss deep sea fishing survey, and non-response in surveys of the dead, and so on. So quantifying survey error requires, I'll just sort of skip to the third bullet there, careful modeling, sensitivity analyses, and the like. A recent example in a patient satisfaction survey, it apparently was possible to, there were auxiliary variables on the database, so it was possible to model response probability in terms of various background characteristics of the patients, of physicians in their study. And one of the conclusions was that estimates of satisfaction may be most inflated for providers with the least satisfied patients. This is contrary, of course, to folk wisdom, which says that the people more likely to respond are the dissatisfied. So it's an interesting finding for that, but also because of the way they did the analysis with a modeling of response probabilities and estimation of the non-response bias. So the conclusions here are a little bit lame, but I think what I'm really trying to say in part is that the quality of survey data does depend on the purposes and the conclusions, as well as the methods and the operations. And also I would agree with Weisberg that the science of surveys and putting together all the aspects is really coming into its own. We're seeing a sort of a transformation into what looks more like a science from a collection of techniques. Okay.
Thank you.
Yeah.
Very interesting. What we'd like to do is give people a chance for questions. It's a little bit frustrating because need to get the microphone to you. So if you put your hand up and maybe think about a question, I'll pass it to you. Maybe you can help me pass it back.
You mentioned a couple of times weights that had to be calculated, and you referred to one survey that was done where you referred to two other surveys and had to decide which of the two to pick in terms of calculating the weights. What are these weights that are being calculated? How does that fit in?
Well, the survey weights are numbers associated with the respondents to the survey, and the weight for a particular respondent we would like to interpret as the number of people in the population that that respondent represents. So we calculate those weights starting out by using inverses of inclusion probabilities and sort of respecting the initial stratification that way, weighting each person up to the number of people the person represents in a stratification. We adjust it for things like non-response. And then we may further adjust it so that if you take the sum of the weights of all people in a certain category, that will give you a known, the same thing as a known number. So in our ITC survey, the sum of the weights for all women in the sample would be the same as the estimated number of women smokers from the CCHS. And similarly for men, and similarly for various age groups. And does that give you an idea?
And certainly that is a source of error. How would you classify that?
The weights do add sort of variability within the analyses. In our analyses, we tend to take the benchmark prevalences as having a very small error that we neglect, so that then the error comes just from the actual construction of the weights themselves, and we can do that by a sort of an expansion, Taylor series expansion of the quantities and so on. So it is possible to take that into account. I would say the main effect of weights on error, though, is that they the appropriate measure of error in a weighted proportion does have is increased over the corresponding formula for a simple random sampling quantity because of that variation.
I could ask a different kind of question. One of the people who influenced me very much, someone probably have never, is long gone, but the younger people will know, Alvin Feinstein. And I think he wrote a book called Clinical Judgment, was one of the things that influenced medicine very much. Introduced Venn diagrams back in the 50s, I think. I don't remember the exact date. He wrote a paper in the early 1960s, a series called Taxonorics. And it was about survey design, or questionnaire design more broadly. He made a huge emphasis on how questions were presented to people, not just what was in them, the wording, but how they were presented in the framework of a page, so you don't miss questions and so on. And looking at some web surveys, that seems to be quite a problem. It's sort of like a within mode variability or error generating thing. Have you any thoughts on that, or looking at surveys as formatted material, how the format and structure of the survey itself determines errors?
Yes, I think it's very important for that reason always to run a pretest and a pilot of any kind of instrument like that, so that you can actually say in a pretest with a few people filling it out, you can see the sorts of things that are causing them difficulty. And then on a broader scale, looking for, say, from a larger pilot sample, looking for things that are missing and misunderstandings that seem to occur. But there, it's true that every survey is different, and the kinds of errors that come up are very often things that you wouldn't have foreseen or expected. Someone who's analyzing the youth smoking survey, for example, is finding that kids filling out a paper and pencil survey don't particularly respect the logic of their responses. If they were given a web survey to do the same thing, that would guide them through the proper logical steps. But would you be missing something from that you can actually see from the results of the paper and pencil? So it's an interesting set of questions.
Feinstein actually came up with a series of rules, I think he called them, about survey design. And today in computer science, the area is generally called usability, and particularly in health informatics, it's a big issue. It'll be interesting to see, has anyone created a compendium of guidance about how to design surveys, particularly online surveys? I don't know what's been done there, but
yeah.
I'm interested in the subjective nature of the interaction between the person being surveyed and the survey, and how that affects your measurement error. So, like, we live in a time of strategic voting, and I find with unimportant surveys, like market surveys, I tend to answer them extremely, because I'd love to change things one way or the other. So, and even just thinking about knowledge about the results, and maybe this would affect something like longitudinal surveys, like, gee, if 20 or 25% of affluent people have herpes, if I knew that, and if you weren't measuring me objectively, but asking if you thought I might have it, if I knew that so many people are likely to have it, I might answer differently about, I don't know, my likelihood or behavior or something. So, I mean, I'm kind of in some ways surprised it's even worth doing a lot of difficult analysis on the data, given this subjective sampling in the first place. How do you, what can you do to try and handle that?
Well, I guess the social scientists in the audience might be able to give a better answer. I mean, the science of measurement is highly developed in one sense, but I guess when we think of our own individual responses, yeah, we might very well wonder how any survey ever finds out anything conclusively.
Are there any people who admit to being social scientists in the audience who are willing to deal with this problem of deviance like Vic? Other questions?
One thing I could say that some of you may know, it's in the last referendum in Quebec, there was a rather stunning triumph. The polling companies in Quebec were able to predict the outcome in spite of the fact that the proportions of people they were asking about how they would vote were over 50% for the yes, or for sovereignty. And yet they predicted the victory for the no side because they were able to forecast correctly the undecided. And that is a tribute to the kind of careful work they do. These were very, very good firms, and also to their analytic capabilities. I don't know if they could do it again, but it was.
I'm worried that there is no uncertainty anymore to this point. Other questions or comments from anyone? If not, Mary, thank you very much.
Okay.
This presentation will be on the Institute website, which is hi.uwaterloo.ca, in about a week's time. So if you want to see the references or go back through any of the slides, the videotape and the presentation will be available.